Hi everyone, and welcome to our video on caring for older adults. This is the first of two videos on caring for older adults. My name is Colleen Wong, and let's get started. Here are the objectives for this module. Identify the vulnerabilities of older adults, define and provide examples of activities of daily living and instrumental activities of daily living, recognize racial disparities in the care of older adults, describe coverage provided by Medicare and Medicaid and the gaps in Medicare coverage, including the donut hole, describe how to spend down and how to find a lawyer in your local area that specializes in medical finance issues, apply techniques to find community resources for older adults, including senior centers, adult daycares, and nutrition programs. The first four of these objectives will be the focus of this video, and the last two will be covered in the second video. There are many vulnerabilities that accompany aging. Multiple chronic illnesses is one of these vulnerabilities. Age is highly associated with burden of disease. 1 in 5 adults have a chronic illness, but 4 out of 5 adults over the age of 65 do. And managing these multiple chronic illnesses is out of the scope of this module. It'll be covered by your medical training, but understand that these are complex patients medically, which occupies a lot of the provider's time. And so oftentimes discussions surrounding social determinants of health and other vulnerabilities don't occur. And because these patients have many chronic illnesses, they are likely on many medications. Polypharmacy, which is the simultaneous use of multiple drugs by a patient for one or more conditions, can be particularly challenging to address in a short visit. But it is one of the things that can have a profound impact on older adults' function, quality of life, financial health, risk for adverse events, including functional declines and death. So many physicians like to do what's called a brown bag review, where patients put all of their prescription medications, vitamins, supplements, over-the-counter medications in a bag and bring it to their doctor's visit. This can be helpful to assess medication-medication interactions, medication-disease interactions, adherence, or really any misunderstanding surrounding these medications. In 2010, 20% of the older adult population was not white, and this percentage is estimated to grow to 42% by 2050. So what does this mean? That there's an increasing diversity of the older white population, and this is partly due to the aging immigrant population. Immigrants who migrate after age 60 are especially vulnerable, as they are more likely to have low income, limited English, lower education levels, and little or no U.S. work experience. And you need to have worked in the U.S. to be eligible for Medicare. So on a whole, the older population is also becoming more educated or increasing their educational attainment. The percentage of high school educated rose from 61 to 75%. In college education, from 13 to 19%, both from 2000 to 2010. But despite educational gains, percentages remain lower compared to all adults over 25, and there is significant heterogeneity in educational levels among different racial groups. That being said, formal education is no guarantee that older adults will be able to navigate the healthcare system. And in fact, many older adults do have inadequate health literacy. This means they have difficulty reading prescription bottles or appointment slips, and they have less comprehension of medical documents. Oftentimes, this leads to higher healthcare costs and higher likelihood of hospitalization. If you want more information, please refer to our module that discusses health literacy. Poverty is another vulnerability of older adults. 9% of older adults are living in poverty, plus 28% are considered low income, meaning that they make less than 200% of the federal poverty level. In addition, poverty in older adults is not equally distributed across the population. The oldest, women, those living alone, foreign-born, and members of ethnic and racial minority groups are at a higher risk for living in poverty. Poverty harms health. Studies have shown an inverse linear relationship between income and mortality. Other studies looking at social economic status and mortality among older adults show that the low income was the most consistently associated with increased mortality. Food insecurity is also an issue. Food security is defined as access at all times to a nutritionally adequate, culturally competent diet that is not obtained through emergency food programs. Higher rates of food insecurity exist among low-income older adults and minority groups than in the general population. Nutritional programs do exist, but only 40% of eligible households participate. There are numerous causes of food insecurity. Food insecurity in older adults is caused not only by financial constraints, but also by physical limitations, lack of social support, poor medical and dental health, and in turn, food insecurity contributes to poor physical and mental health, medicine non-adherence, and poor chronic disease management. When it comes to mental health issues, there are higher rates of depression in older adults, especially those with medical comorbidities. Even though depression is prevalent, it's often unrecognized and untreated in older adults. This may be because the symptoms of depression can mimic medical illness or be attributed to medication side effects or life events. There are also issues of cognitive decline and cognitive impairment. Cognitive impairment increases vulnerability of older adults due to its effect on executive tasks such as driving, medication, and financial management, and so age is associated with an increased need for assistance. Much of the caregiving for disabled seniors is informal, provided by a spouse or another adult, and this dependency is related to the terms ADL and IADLs. What are ADLs and IADLs? Well, ADL stands for Activities of Daily Living, and they refer to the day-to-day activities that individuals usually do without assistance. IADLs are instrumental activities of daily living, and they are day-to-day activities that are required to live with total independence. Here are some examples of ADLs: dressing, eating, walking, transfers, toileting, and hygiene. And IADLs: shopping, housework, accounting, food preparation, transportation, telephone and technology use, and taking medications. So it's pretty easy to see that if someone was unable to do their IADLs and or their ADLs, that they would need assistance, and it would be very challenging to live alone. Now let's talk about racial disparities in the care of older adults. We know that in addition to significant income disparities based on race, there is a greater and accelerating gap between the median net worth of African American and Latino families compared to that of white families. In combination with the changing demographics, the racial wealth gap means that seniors looking for long-term care will be more likely racial or ethnic minorities and have fewer resources to pay for their care. And so aging minority seniors will have fewer choices about how and where to receive the long-term care that they need. As the composition of the population of adults over 65 in the U.S. has changed, the number of minority residents in nursing homes has increased, while the number of white residents in these nursing homes has fallen. And racial and ethnic minorities are more likely to live in facilities with fewer resources, lower staff nursing ratios, and lower quality indicators. A high concentration of minority residents correlates both with lower quality of care and greater dependence on Medicaid, which under-reimburses for nursing home care. And so these facilities, they do not have the resources that they need to improve quality. So one way to address nursing home disparities is to improve Medicaid reimbursement. When it comes to home health services, minority patients experience more adverse events, less functional improvement, and worse patient experience. And as with nursing homes, home health agencies with a higher number of minority, specifically African American clients, have lower quality of care scores. Furthermore, African Americans are less likely to have advanced directives or to enroll in hospice, and more likely to disenroll if they do. African Americans and Hispanics are less likely to be assessed and treated for pain, and they find it harder to fill prescriptions for opioids. Current efforts to stem opioid abuse and addiction are warranted, but they create an additional obstacle for minority patients who need these drugs for pain relief. Shifting gears a little bit, now let's discuss Medicaid and Medicare coverage, because health coverage, or lack thereof, is an important matter when discussing care for older adults. So, Medicaid and Medicare, what are they? What are the differences? Well, Medicaid is a state and federal program that provides health coverage for some low income people, families, and children, pregnant women, the elderly, and people with disabilities. Each state operates its own Medicaid program within federal guidelines, and Medicaid is funded through both federal and state funds. So while states are required to provide health insurance coverage to specific groups, each state can determine its own income requirements and eligibility guidelines. As a result, Medicaid eligibility and benefits can, and often do, vary widely from state to state. Now for Medicare, there are 4 parts of Medicare, Parts A, B, C, and D. Part A provides inpatient and hospital coverage. Part B provides outpatient and other medical coverage. Part C offers an alternative way to receive your Medicare benefits. And Part D provides prescription drug coverage. 95% of older adults are eligible and receive at least Part A of Medicare. However, Part A does not provide comprehensive coverage and excludes services such as eyeglasses, dentures, and long-term care, which can be important for the older population. The Congressional Budget Office estimates that Medicare only covers about 45% of what the average beneficiary needs. And in 2007, the median out-of-pocket spending was $3,138. The top 10% of out-of-pocket spending was above $7,800, and this is annually. So to help cover the high costs, most beneficiaries have supplemental coverage through private insurance, Medicaid, Medicare Advantage, or Medigap plans. MA, or the Medicare Advantage plans, are offered by private insurance companies that receive a fixed amount for each beneficiary covered under that plan. And so this is not traditional Medicare. All of the services are provided by that Medicare Advantage plan. Medigap coverage is also sold by private companies, but this provides varying levels of coverage and costs, and this is in addition to the Medicare plan. So 23% of Medicare beneficiaries had a Medigap plan, and 40% of Medicare beneficiaries are also enrolled in Medicaid. Despite Medicare coverage, a low-income beneficiary may still pay 1/3 or more of their income out of pocket to healthcare costs, with the majority of this going towards prescription medications. Medications that are not available generic, those that treat conditions without noticeable symptoms, and those that are expensive are more likely to be reduced or stopped. And so older adults living on fixed low income without drug coverage may self-ration or stop taking their medications altogether because of the price. So Congress passed the Medicare Prescription Drug Improvement Modernization Act of 2003 to provide older adult patients with prescription drug benefits, and this is part of Medicare Part D. But Medicare Part D still has this built-in coverage gap, which is referred to as the donut hole. Okay, so let's discuss the donut hole. The way Medicare Part D is set up is first you have to pay your annual deductible, and this is about $310. Then you pay 25% of the next $2,540 in drug costs, and this ends up being about $635. Then you get no further coverage until the out-of-pocket spending reaches $4,550. So this means a total of $6,440 has already been spent on drugs. Then, and only then, does catastrophic coverage begin. And this covers 95% of future drug costs. Nearly 20% of people reach this donut hole, or this coverage gap, and about 12% reach the catastrophic level. Remember, this is annual, so the Affordable Care Act does provide a rebate to Part D beneficiaries to try and help during this coverage gap period. The rebate is $250, and it's for the people who, again, fall into this donut hole, and it reduces the copay during the gap to 25% instead of 100%. And that concludes our video on caring for older adults. Thank you.